Good morning, good afternoon, good evening, wherever you are on this planet. Welcome on behalf of the Education Committee of the ISPN to the first of the ISPN Clash of the Titans, a debate designed between two of the most expert pediatric neurosurgeons that we have in this on this planet. And we will have a whole series of these to come. But before we formally start the debate, it gives me great pleasure to invite Professor Salomao, who is the president of the International Society of Pediatric Neurosurgery, and who's very kindly gracing this occasion to officially inaugurate this series of Clash of the Titans. Francisco.
Oh, good morning, good afternoon, good night. Dear colleagues, dear friends, it's my great pleasure to inaugurate the cycle of debates because scientific ISPN, scientific activities of ISPN is one of the most important things we have. And especially in current days in which most of people are confined. So we have very good reasons to remain at home and to listen to our colleagues, to listen to these lectures. I'd like to thank Sandip and Elsie for the nice work. I would also thank Ken's effort to make this meeting possible. And my greetings to our panelists, Shlomi Constantini, Michel Zerah, both great friends for a long time. And a warm welcome to all our audience. Enjoy it. Please, Sandip.
Thank you, Francisco. It gives me great pleasure to introduce to you the two panelists for today. As you know, we're going to debate on the topic, prenatal radiological investigations are useful in pediatric neurosurgery or are not useful in pediatric neurosurgery. Speaking in favor of prenatal investigations is a man that every person that does pediatric neurosurgery in the world is well familiar with, Professor Michel Zerah. He's a professor of pediatric neurosurgery, as you know, at the Neckar Hospitals in Paris and a past president of the ISPN. Apart from the fact that my claim to fame in pediatric neurosurgery is that he's a friend of mine. Speaking against the prenatal radiological investigations is another very, very close friend and a man who I almost have begun to emulate in many aspects of my neurosurgical life. And we certainly share a lot of common viewpoints on the world, is Professor Shlomi Constantini. He's the head of pediatric neurosurgery, as you know, at the Dana Children's Hospital in Tel Aviv, Medical Center in Tel Aviv. He's a past president of the ISPN and a past secretary of the ISPN. Without much ado, reminding you of this, the first Clash of the Titans, the topic, radiological investigations in the prenatal period are useful to a pediatric neurosurgeon. All yours, Michel. So the way we will do it, that Professor Zerah and Professor Constantini speak for 20 minutes in favor and against. And then you have the opportunity to post your questions. You note that you can post them on the chat box in the Q&A, and then we will have a few minutes of them being able to answer your questions. With all yours, Michel, you have 20 minutes from now.
Can you see my screen?
Yes, perfectly. Thank you.
Okay, so hello everybody. As it was said, good morning, good evening, good night, something else. I'm very happy to be there with you, and I'm very happy to inaugurate this Clash of the Titans. When I listened to this title, I remember that the first Clash of the Titans was 13 years ago in Liverpool during the ESPN meeting with Dashlin Pong, with me and Dashlin Pong. And in fact, when William Harkness that reported 1 year after in the ISPN meeting in Cape Town, you can imagine how was this first controversy, and I hope that we will not reach that point today with Shlomi. Anyway, when I read the title, it was evident for me that it's very simple to answer with only 2 slides. The first slide is just to suppress prenatal, and when you read in pediatric neurosurgery radiological investigations do not serve any use, you can imagine that there is absolutely no discussion and there is no debates. Also, when you suppress neurosurgery and you read in pediatric prenatal radiological investigation do not serve any use, there is no discussion. So what is so specific in neurosurgery and in prenatal neurosurgery to raise this kind of debate? First of all, I think that the first mistake most of us do, because our training is in or in adult or in children, but very few of us in very young children in neonatology and in antenatal problem, is that we all imagine that there is a wall before and after birth, which is a completely wrong way to think, and we must get rid of that. I just want to give as an example what are the vascular malformation. Of course, some of them start before birth, some of them start after birth, but if we consider the most frequent of them which start before birth, we know that the diagnosis is completely doable before birth, and only by ultrasonography and Doppler. It's possible to do the diagnosis, it's possible to do an accurate diagnosis and to find out the feeders, the consequences of this malformation, and even to have an angiogram on the prenatal MR. And what is very important is to realize that only this investigation, this radiological investigation, help us to make a diagnosis, to make a prognosis, to give information to the parents, to organize the follow-up, to organize the neonatal period, to organize the in utero transfer if needed, to discuss normal or C-section delivery, and to organize the things with all the team ready. And in fact, you can realize that all what I've listed is completely true for any our prenatal problem. And what is important to realize is that we need to work in a team. And what is this team? This team is, of course, the obstetrics and the fetal medicine department, but we need to work as twin with our colleague of the Department of Pediatric Imaging, and I spent, when she is not in Israel, many hours every week with Catherine Garel, with my colleague, with a straight antenatal prenatal radiologist, and we are working together for more than 30 years now. Of course, there are ethical, social, legal, technical, economical consideration. And for example, you know that we need to behave differently all over the world. And here in this map of the WHO, you can see the possibility of termination of pregnancy all around the world. And you can see the huge discrepancy between the north and the south parts of the globe. But anyway, this is not the problem today. When we focus to our specific problem today, the discussion is completely elsewhere. And if we have this discussion, it's because we have now antenatal treatment. And as we are surgeons, we need to deal with all the antenatal treatment, which means that we need more and more accurate diagnosis. We need more and more early diagnosis. We need more and more competency and raised a new specialty, which is fetal medicine. And within this fetal medicine, a new super specialty, which is a fetal surgery. And within the fetal surgery, a new super specialty, which is fetal neurosurgery, which seems to be a very small part of fetal medicine and also a small part of pediatric neurosurgery, but I want to convince that this is not. And this story starts 40 years ago in California by the first meeting about fetal treatment, and we found the base of antenatal surgery. To do antenatal surgery, we need to have a certain diagnosis. You need to prove that this is you have a severe diagnosis and an antenatal evolution, and we can't do that without prenatal radiological investigation. And also, where are we as neurosurgeons? We are not the GAFA, but we are in the top 4 of all these diseases. And I want to show you how we are connected with all our colleagues of antenatal surgery and antenatal radiology. First of all, one of the most frequent is the congenital diaphragmatic hernia. You know that it destroys the lung antenatally. The diagnosis is, of course, done by only the ultrasound, and has been developed an in utero treatment at the beginning by open fetal surgery, as you can see on this slide, with a patch on the diaphragm with awful results. That's why has been developed a clip on the trachea, then an intubation and a balloon within the trachea. And this is where I wanted to go, is that among the tools we have all in antenatal surgery, we have the conjunction of imaging, which is ultrasound, with not only a tool of diagnosis, but also a tool of treatment, and the endoscopy. And you have seen the endoscopic guided by ultrasound intubation, and I will be short on that. You see that it will be easy for my colleagues to put down a balloon, to inflate it, and to leave it in place during all the pregnancy to treat this diaphragmatic hernia. Then the second point is a twin-twin transfusion syndrome. Again, the same thing. You all know this syndrome. It's on monochorionic twins. One is a donor, the other one is a recipient. This one has not enough, this one has too much, and the both of them are completely damaged by this intrauterine transfusion. And the only way to treat that is to disconnect the connection between the two of them. And there again, you can see here an antenatal endoscopy. You see one of the twin. This is the head, the shoulder. I will be short. We will look for the second one. This is the foot of the first one. The second one say a little hello to everybody in this room. And we will reach the chorion, and the work will be done guided by the ultrasound under endoscopy by the laser. And you can see here the disconnection between the two circulations of these two twins. So again, our tools are endoscopy, ultrasound, and laser, which means that without imaging, it's impossible to do this kind of surgery. And the third example are the lower urinary tract obstructions. The most frequent of them is posterior urethral valves, which destroy completely the kidney. And again, we have our tools, the endoscopy, the ultrasound, the laser, and the shunt. And you can do vesicoamniotic shunting or fetal cystoscopy. And you see here the use of the ultrasound, again, the radiology to put a shunt. And here, and look at these images because we will see some which are really similar to this one later on, to do by laser opening, the opening of the membrane in these children. So now we are going to move to CNS malformation. First example, you see the suprasellar cyst, which is diagnosed, of course, by a prenatal imaging. You see that there is no ventricular dilatation, so we decide to wait and look to what happened 1 week after. And of course, we need to have imaging to know and to see the difference between both huge ventricular dilatation. We are at the 28th weeks, too early to provoke delivery. So with the tool we have discussed, which mean ultrasound, endoscopy, and laser, and it's exactly the same thing that you've seen previously, guided by the image. You can put an endoscope within the ventricle to find out the roof of the cyst, and using the laser, as we have done previously, it's possible to make a hole on the top of the cyst to go down within the third ventricle. You can see perfectly the base of the third ventricle, and you can do your ventriculocystostomy here as you do it in postnatal. And you can see all the vessels you have, and it's always the same thing when you do this kind of surgery antenatally. And as usual, you will see the opening of the ventriculocysternostomy, and you see the movement of the floor of the third ventricle. 1 week after, you have decrease of the size of the ventricle. We go back to small ventricles before the delivery, but recurrence after birth, as in all our cases except one, which means that after birth you need to do another ventriculostomy, but just one, and the child is perfect 3 years after. And at the end, and because this is a major topic, I suppose, what can we say on dysraphism? Antenatal diagnosis is very, very easy before birth, and I will not spend time on that. And at this point, you can discuss termination of pregnancy, postnatal management, and prenatal surgery. One can be said on radiology. It is clear and proved in all the papers that only by ultrasound, but also by MR, you can do a perfect diagnosis and prognosis before birth. And if you look to the difference between the early ultrasound and the clinical examination after birth, you have only one level of difference. Second thing is that you know that now we can do antenatal surgery. All of you know the results of the mumps on the shunt, on the Chiari, on the gates. And this has been reproduced in many series, and now we have the long-term results of the mumps. Here an image of our series, and you can see that the Chiari disappeared in 1 week, and again an advantage of the imaging. I will not discuss, because it's out of my subject, the advantage of disadvantage of open and endoscopic surgery, but When I look to our series, I want to focus on that. On the 136 cases referred to our clinical trial, we have had 20% of misdiagnosis. What they were, here an example, a woman proposed to termination of pregnancy, she refused, she came to us, we redo the ultrasound, and you can clearly see that this is not myelomeningocele. The skin is normal, you have the spinal cord attached only by a single tract, which goes up and down within the spinal cord, and a very narrow spina bifida. It's of course an antenatal LDM, and we decide to continue the pregnancy. This is the ultrasound after birth, and you can see how similar, because as you remember, there is no wall between and after birth between the antenatal ultrasound and the postnatal ultrasound, and we go for surgery. And you know how simple is the surgery. You just have to cut the bands which attach one part of the spinal cord to put it back, and the child is cured, and he is completely normal, and we published that 4 years ago. But sometimes it's more complicated. You can see here that the spinal cord goes down and back, attached on a normal skin, and here is an opening at the top of the myelomeningocele. And just like that. And when you look to the aspects after birth, many people would say that this is a myelomeningocele, but this is not, because there is absolutely no placode, and the spinal cord is attached only somewhere here, as you can see on the antenatal ultrasound. And if you look to the aspect at the moment of the surgery, it's exactly the same thing than the LDM. You have the spinal cord, which is coming here, attached by some fibrous bond, and it's very easy to detach it, to put it back, as you can see here, and to close the skin. And again, this was not a myelomeningocele, so the prognosis is completely good, and that's why we have proposed to design a new entity which is in between the myelomeningocele and the LDM, that we have called the Miel DM, to explain all this range of different malformation at this level. And last but not least, 3 years ago, I went to one center to see an antenatal surgery. And I was surprised by two things. The first one is that there is no neurosurgeon in the operating room. There was an obstetrician, and there was a neurosurgeon, and there was a general surgeon who is doing the surgery. The second thing is that it was not a myelomeningocele. If you remember what I have seen, but nobody in the room was able to analyze these images, this looked like much more a closed Miel DM. You see the spinal cord here, you see the normal skin here, but as I was invited, I say nothing. And if you look to what happened during the surgery, you can see here by endoscopy the dome of the malformation, and you see that the skin is completely normal, And imagine what happened. They were obliged to puncture the sac. Then, I'm sorry. They were obliged to puncture the sac, as here, then to cut it just to reach the malformation. And then inside, it was exactly what I have shown you on my postnatal cases. It was exactly the same thing. And they spent 1 hour to imagine what was this stalk before cutting it, because they do not know the anatomy, this lesion, their anatomy, and their cause. Which means that, as a conclusion, antenatal diagnosis, counseling, and treatment are here to stay. If we don't be involved, at least in counseling, and for some of us in treatment, there is a lot of people behind the door who are ready to take the empty place from us. And we need to keep in mind that they don't know the diseases they treat prenatally these children, and that the postnatal evolution will be for us, who will take care of these children, whatever happened previously during the rest of their life. And for me, it is less and less acceptable and ethic to see inaccurate diagnosis, wrong decision, and useless fetal deaths and or misinformed parents. That means that as for our postnatal treatment, we need to be very efficient, and as the best exam in most of the cases is the ultrasound, we need to spend time with our colleagues, radiologists and obstetricians, and be involved in a multidisciplinary antenatal team. And we must keep in mind that 28% of all antenatal cases are CNS problems. So this is the end of my talk. I'm sure that it will be really friendly with Shlomi, and that next year, Mr. Sandip Chatterjee will not show us this kind of picture. And if he did, I'm sure that we will be ready to give him our answer. Thank you for your attention.
Thank you, Michel. This is the first time I've seen that the moderator of the debate is beheaded before the debate is over. But thank you very much. That's a fantastic talk, and I'm sure you've all appreciated Professor Zerah's contention about the need of prenatal investigations, not only for accurate diagnosis, for prognosis, and of course for this emerging fantastic field of antenatal surgery in utero, which, as I shown you, can produce fantastic results. Now, those of you that have questions for Michel, please feel free to put it down in the Q&A at the bottom of your screen, and we'll take those at the end of the talk by Professor Shlomi Constantini. Shlomi, you completely disagree, I know, and you have 20 minutes to air your disagreement. All yours.
Very good. I'm trying to share my screen. Sharing. Okay. 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 Do you see my screen?
Yes, yes, indeed. Thank you.
Okay. Okay. My assignment, thank you, Sandip, and the people who have joined us, is to speak about prenatal screening. I will refer to it as PNS, and I have been assigned the against topic. Why doesn't it work? Just a minute. I'm not sure. Yeah, I would like to convince you during my 20 minutes that prenatal screening is highly overdosed in many countries, that this overdose may be fueled by family anxiety and medico-legal considerations, that prenatal screening overdose has become a financial industry, and that prenatal screening should be much more tailored than it is now in many countries. This is our team. This is Liat Ben-Sirah. She's performed about 6,000 prenatal MRIs. This is Gustavo Malinger, our ultrasound maestro. And yes, they do work with the same incredible lady that Michel is working, who works in Paris and Tel Aviv. So we are connected directly to Michel, and we come from similar schools. Prenatal screening is divided into genetic or morphological. Morphological can be by ultrasound or MRI. Remember that prenatal screening is technology-based, and technology is always expensive, it has wear and tears, it creates accidents, it may mislead you, it creates dependency, and it introduces options. I often wonder whether technology makes any difference. On the left is the Inca, on the right is our operating room from 20 years ago. And this is a picture I took about 3 years ago, and I counted 25 computers and 19 monitors. We may be overdoing it with the available technology that we have. And this is from Ashraf. When you have a new technology, in the beginning, you're so happy, then you become depressed, and then you stabilize somewhere in the middle. Well, debate. What is the value in debate? It traces back to ancient Greece. it was further developed by debating societies that emerged in London in the early 18th century. It challenges opinions and it broadens perspectives. I want to start by two stories. Here is story number one. Meet my friend, Professor Yuval Yaron, who is the head of the Prenatal Diagnosis Unit at the Tel Aviv Medical Center. He participated on a debate on the value of amniocentesis, also talking against, although he does it all the time. He decided to undergo a genetic testing himself. What did Professor Yaron discover? He discovered that he has a microdeletion in chromosome 15q. What do we know about microdeletion in chromosome 15q? This is a paper on this issue. We know that these people have developmental delay, motor delay, speech delay, and also ADHD, etc., etc. So, would you have chosen to abort Professor Yaron based on his genetic testing? Well, you might have, his parents might have. So he says in a humorous way that the only thing he agrees is that he has OCD, but he insists that OCD should be called CDO because this is the right way to press the letters. Story number two, opinion on terminating a pregnancy. Expecting parents provide the following history. Father has syphilis, mother has TB, first child is blind, second child died during pregnancy, third child is deaf and retarded, fourth child has TB, an extremely poor family. What would you recommend? When you provide this query to medical students, about 95% are pro-abortion. Well, you've just aborted Beethoven. This is a nice story. The problem with story number two, that it may be a fallacy. It has a questionable origin, and a prominent Roman Catholic who was promoting pro-life movement may have invented it or changed it all. But in any case, it is a good story. When is screening justified? Colon cancer, early diagnosis, better prognosis. Therefore, it is recommended in the US above the age of 45 to perform a colonoscopy every 10 years. Yearly mammographies after the age of 40 has been shown to reduce the risk of dying from breast cancer. But why over the age of 45? Why not start at the age of 20? And why not do it every year? The reason is obvious. There is a concept of cost effectiveness and prioritization. What does the Webster say about cost effectiveness? It is a tangible benefit produced by money and resources spent. The cost of ultrasound in Israel is between $300 and $700. The cost of prenatal MRI is between $800 and $1,100. Most women perform several ultrasounds during their pregnancy. What about the anxiety before and after doing the screening process? Is it a negligible factor? How many tests do you really need to do in order to find one important case? 1 in 10, most will agree. 1 in 100, you would question. 1 in 1,000, it's a problem. So this is a common dilemma with every test, and certainly with every additional test we introduce into our medical armamentarium. What is the cost effectiveness of prenatal screening and how to calculate it? This depends on the available sources. In some countries, perhaps there are unlimited sources, the geo-religious affiliation, and the established outcomes and benefits of prenatal screening. Do we really know it? So when we searched cost effectiveness in prenatal screening, we found very, very little information out there in the literature. We don't really know. Why do we perform prenatal screening? 4 reasons. The first is for obstetrics consideration. Michel introduced that. Second is decision about termination of pregnancy. The third would be reassurance for the parents regarding the health of the fetus. And the fourth would be decisions regarding intrauterine manipulations. Let's go one by one. Obstetrics consideration. The time of delivery, the type of delivery, the place of delivery, this is all correct. but would one ultrasound a month before expected delivery be sufficient for this purpose? This is, by the way, the routine of the ultra-Orthodox Jewish community in Israel, just to wait a month before delivery. What about abortion? When you do prenatal consultations, you usually encounter 3 patients group. The first group is due to religious, legal, cultural reasons will never abort. On the other side, there are people who would abort even for an 0.5% of any abnormality. They don't want to take any risk. This is, by the way, a small group. And then in the middle, you have the majority whose main concern is whether the abnormality that we're going to find will significantly impair their child's chances to become an independent adult and integrate into normal schooling. These 3 groups are different in different countries and different regions around the world. There are additional considerations. There are religious considerations. There are legal considerations. Look, for example, in America. Georgia, Ohio, Kentucky, and Mississippi passed a bill which prohibits abortion after 6 weeks. This is a criminal act, and anyone performing an abortion over this time can go to jail. What about the psychological effects? On one hand, reassurance to the parents, to the mother, that their fetus is healthy. On the other hand, the stress that is around finding any mild abnormalities, and we've all encountered families whose fetus has been found to have some mild abnormality. High pregnancy anxiety can affect the gray matter. This has been shown. Stress during pregnancy can affect intellectual and language functioning. Maternal stress can affect the infant temperature. So do the psychological benefits of reassurance outweigh the potential induced anxiety? I'm not so sure about that. What about intrauterine treatment? And I will speak only about CNS treatment, and forgive my nihilistic approach. Prenatal treatment of hydrocephalus, this is dead. It was really, really active 20, 30 years ago. Almost nobody does that. Closure of encephalo cells. Well, it's quite exotic. I know our friend Sergio Cavallero is doing it in Brazil, but this is quite exotic. Diaphragmatic hernia is extremely rare. And closure of meningocell and open defects, well, forgive my nihilism again, it is still rare, it is still controversial, and open defects is a disease which is going to disappear from this world, I presume, in the next decade. Now, what about MRI versus ultrasound? For ventricular size, ultrasound is sufficient. For corpus callosum integrity, ultrasound is sufficient. For vermian integrity, ultrasound is mostly sufficient in good hands. For cystic cavitations, ultrasound is mostly sufficient in good hands. For bleeding versus tumor, it's complementary. Ultrasound has the advantage of introducing Doppler, and MRI has the different sequences, so this is complementary. Small heterotopias and focal polymicrogyria, MRI seems to have an advantage over ultrasound, but is it sufficient to recommend termination of pregnancy? Are we practicing false positive tool? What is the prognosis? Can we really predict it for very small cortical changes? The advantages of MRI over ultrasound: a large field of view, no image degradation from skeleton, obesity, etc., superior soft tissue contrast resolution. It may have an advantage in CNS anomalies. Is that right? What is the disadvantage of MRI over an ultrasound? MRI screening done before 24 weeks has many false positives and is very difficult to interpret accurately. It is more expensive, it is less available. It will not save a postnatal MRI for those who are candidates for surgery after birth. This is a paper written a few years ago, but I just like the conclusions. Is fetal magnetic resonance imaging superior to ultrasound? And I just would like to read you a few of the conclusions. The claim for superiority may be biased. We may be over-enthusiastic because it is a new technique. We too often, what we do is a comparison between a referral transabdominal ultrasound done by a gynecologist and a tertiary level MRI done by an expert. This comparison is not fair. We should compare the prenatal MRI with the ultrasound of a maestro like a Professor Mallinger in our institution. MRI may be gaining popularity because of a lack of expertise in most ultrasound units in visualizing all parts of the brain. I swear, Mrs. Sodini, I saw your baby in there just a minute ago. Well, not all ultrasonographers are trained in neuroanatomy. Fetal MRI performance, a reading requires sub-specialization. Some say that you need to do between 500 and 1,000 prenatal MRIs in order to know what you're talking about. And what are the additional considerations? The cost, the industry. Prenatal screening is a financial industry and a lot of people make their living on it. And the medico-legal aspects. In Israel, it has become a primary reason for lawsuits. What are the reasons for lawsuits regarding prenatal screening? Not performing a standard test, or what they consider is a standard test, missing a significant morphological or genetic finding, misinterpretation of a known finding, insufficient information sharing with the family, opinionated consultation. In my opinion, it is nothing. Badly filled or lacking of proper informed consent. Wrongful birth is a very common lawsuit in Israel, which means if I would have known, we would have aborted our baby. It's a little bit of a strange concept, but it is a concept accepted by most legal systems around the world. So if I was born wrongfully, you should compensate me for all my extra expenses and pain and suffering. So how to prevent the clash between the perfect baby society? We want our children to be perfect, not a little bit less than perfect, and non-justified tests. How to do it? Take what you need. We have to be more selective and not to do a lot of tests on these small minor abnormalities. So these are the conclusions. Prenatal screening has a questionable cost-effective ratio. Cost-effective ratio must be researched more critically. Geographical, religious, and legal variables should be considered while deciding on the intensity of trimming and prenatal screening. The psychological burden on mothers and fathers, where a minor finding is found, may be underestimated. Prenatal screening may have a significant false positive rate leading to extra terminations. Prenatal screening is a financial industry fueled by family phobias and medico-legal concerns. These confounding influences should be neutralized against the wonderful cases that Professor Zerah has shown us. This is Jesus among the doctors from the Prado in Madrid. It would be nice if we had a wise man giving us advice, and this is my team in Tel Aviv. Come to visit us. Thank you very much.
Thank you very much, Shlomi. That was a fantastic talk. And as you probably observed, Professor Constantini talked about the cost effectiveness, the issue of maternal anxiety, and of course the medical legal issues, all of which he uses as reasons to not be too excited about doing too much of prenatal investigations. Right, we have a few questions, but before we go into the questions, I'm going to ask the same question to both the panelists. And this is this, that if we are talking about prenatal investigations being a guide to whether you advise the parents to go on with pregnancy or to terminate pregnancy, is there a cutoff period for accepting termination of pregnancy where it would be useful? In other words, would you say prenatal investigations are worthwhile if termination of pregnancy is allowed up to 30 weeks, up to 24 weeks? if you do not allow termination beyond 20 weeks, then it's no use. Is there a cutoff, do you think? And I'll ask Michel first, and then I'll ask Shlomi this as well. Because all over the world, as you've pointed out, there are different cutoffs accepted by different governments based on religious, legal, whatever be the grounds. So is there a cutoff? And we say if you terminate pregnancy beyond, not beyond so many weeks, it's pointless doing too much of prenatal investigations, because before that you wouldn't know most of them. Michel?
Yes, you know that I live in a very, very strange country because there is no endpoint for termination of the pregnancy. That means that we can do termination of the pregnancy until 5 minutes before the delivery. That means that it's allowed in my country to do a termination of pregnancy at the 40 or 41st week. In the opposite, as soon as the baby is born, even it's a great premature at the 26 weeks, it's completely forbidden to do an euthanasia and to stop the treatment. Which means that we are in a very strange position, but the advantage of that is that when we are on the borderline, for example, at the 24th weeks, we can say to the parents, well, this is the point we are now. We can wait for 2 weeks or for 4 weeks, if you agree with that, to redo examination. And if at this point there is a worsening and you consider that it's better to do a termination of the pregnancy, it's allowed. But the main point is that it's never a one-to-one discussion. Because we have in France groups, antenatal groups, we meet once a week, and the termination of the pregnancy must be agreed by a referential multidisciplinary meeting. These are the two specific points. So I think that to be able to do the termination until the end of the pregnancy, that's mandatory to go in front of a multidisciplinary meeting are the two specific points in the country where I live. We change, I think, the discussion.
But everybody doesn't live in France.
No, I know that.
Some of us live in countries where you're not allowed to terminate after 24 weeks. Shlomi, what do you think? Is there a cutoff? Is there a cutoff? I mean, you would say if you cannot terminate beyond so many weeks, you should not bother doing prenatal investigations at all. Would you have a cutoff for that?
I would say 18 weeks, because most of our central nervous system discussion and malformation are diagnosed during the ultrasound at the second trimester of pregnancy.
Okay. Shlomi?
Well, Michel, you are not the only one living in a strange country, okay? I thought we specialized in this, but maybe you're right. Well, in Israel, until 20 weeks, and some extended to 22 weeks, you can do abortion by curettage by a regular committee. Above that, you have to go to the Supreme Committee until delivery. And that is done by early delivery plus sometimes feticide. For convincing the Supreme Committee, you have to bring letters claiming that the chances for a significant, defined significant morbidity is higher than 30%. So this is the law in Israel, but you can abort almost at any age, but you cannot abort for anything at a more advanced stage.
Okay, we'll take some questions from our viewers, and I'll take the questions from Michel first. Michel, there is a question for you. In fact, a number of people have asked this question. How much do you think are the maternal risks of doing in utero surgery for something like an open meningomyelocele today?
It remains high. And the main risk is we have solved the problem of pulmonary edema with the new treatments, but the risk for the uterus and the rupture after during the second pregnancy remain high. It has been studied now in several papers, and it's probably the risk of it's over 20% and maybe over 50%. And this is the main argument to do this surgery by endoscopy, because it seems that if the risk of premature nature during the pregnancy where the surgery is done is higher than with open surgery, the risk with the next pregnancy is lower if you have done the surgery by endoscopic surgery.
Okay, a question to both the panelists. Yeah, Shlomi, you want to say, go on.
Yes, I just want to say, there's always this prenatal correction of meningomyelocele is so exotic and people are sucked into it. But we're talking about 1 in 1,000 in the whole arena of prenatal screening ocean. I just want to say, in Israel, we have 170,000 births per year. I served 9 NICUs. Last year, I saw 2 open defects, not only because of abortion, because of a combination of things. So open defects are going to dissipate. And about maternal risk, there is a fantastic review by Yuval Solomon in Neurosurgical Focus.
Okay, the next question is in fact to both, but I'll let Shlomi answer that because I think you talk more about it. The questioner wants to know, when would you ask for an MRI prenatally as opposed to an ultrasound? What specific situations would you specifically ask for an MRI rather than a prenatal ultrasound?
Yes, well, I try to answer it, but I will try to summarize. First of all, before you ask for a prenatal MRI, look who did the prenatal ultrasound. Is it a maestro who works in a tertiary center, who is an expert on the neuroanatomy of the fetus? Or is it a gynecologist that works in a remote clinic somewhere? So most would go for an additional ultrasound to decide on the value of MRI. Then you have to meet the parents and see to what group they belong. If they belong to the no abortion group, then there's no sense to do an MRI. You'll do an MRI after birth. If they belong to the majority, look, what is the anomaly? I resist the notion of doing a prenatal MRI for a unilateral isolated ventriculomegaly of 11 millimeters where everything else is normal by a fantastic ultrasonography. So you have to decide case by case. If the MRI will change the formula from live to termination, then an MRI is justified. But you cannot do the MRI before 24 weeks, or either you'll get a lot of false positives.
Michel, on that note, I know you have some strong feelings about this. What do you think, how dangerous are the false positives on prenatal MRI, do you think? And what about false negatives in a prenatal ultrasound?
You know, the MRI is, I completely agree with what Shlomi has told. We do very, very few antenatal MRI, mainly to see the brain and the small anomalies in the brain. And when we want to continue the pregnancy and when we discuss surgery, for no other reason, we propose MRI. Considering the false positive or the false negative, I think that if you add the ultrasound, and the advantage of the ultrasound is that you can repeat them and see the evolution, sometimes the MRI, and in some cases, when you have a doubt on genetic disease, the amniocentesis, I would say that we have very few false diagnoses, very few.
There's another question for you, Michel, and this is the questioner wants to know, how do you deal with change of fetal position while you're doing fetal surgery? We
do an anesthesia. First of all, the baby is anesthetized. He gets analgesia just at the moment of the surgery, and so he do not move. And when we put the back outside of the uterus, my two obstetrician colleagues hold the child we are doing the surgery.
Okay, here's a question for Michel. Wrongful birth compensation. This is something that we're even seeing in this part of the world now. How serious is this a problem? And once you answer the question, I'll tell you why it's a very serious problem in some parts of the world. But
what does it mean?
Often do you see this wrongful birth compensation problems as far as prenatal interpretation of prenatal radiology is concerned?
I'm sorry, Sandip, I don't know what it means.
Shlomi, you use the word
Yes.
wrongful birth, so you can explain what it means and then tell us about how significant that is.
Yes. The concept is the following. I mentioned it in the slide on lawsuits. The concept is like this. An anomaly was not found or found and not explained in a proper way to the parents, or found and explained but not documented to the parents. And the parents claim that if they would have known, they would have aborted the baby. The baby is here, he's alive. And they claim that all the pain and suffering of the baby should be compensated to them by law because he was born wrongfully. It's a little bit of a distorted logic, but it's a logic that is being taken by most of the law systems. This is the concept.
So what happened in France is that we had a law 15 years ago after a lawsuit which go up to the Supreme Court. And because of that, the insurance of my colleague obstetrician rise incredibly, and half of them decide to stop to do antenatal ultrasonography. As far as the government decide to pay most of the insurance for the obstetrician to recover some people who want to do obstetrics. But it's really a problem. Of course, it's really a problem. And now it's in the law in France.
Sandip, why did you ask? What did you have in mind?
Well, this is because for the first time ever, we've had a medical legal case in this country, in my country, in India, where the parents are suing the prenatal ultrasonologist, the neurosurgeon, the obstetrician, saying that we have a child who was born with a neural tube defect and we were not warned. In fact, it wasn't a neural tube defect. It would fall into Michel's category of a mild LDM. It was one of those gray areas between an LDM and an open meningomyelocele. But they are claiming compensation, saying the child unfortunately was operated, and after the operation, the neurodeficit which the child was born with got worse. So the parents are now suing everybody, including the prenatal, the neurosurgeons and the neonatologists who saw the child prenatally, saying you should have told us to terminate the pregnancy, and otherwise you have to pay us compensation for bringing up this child. As you know, we have no social support system for these children in our country, which means it's a huge compensation. This is why I asked this question, because in my own practice, and we don't have the benefit of a big prenatal screening committee, as it were. I have neonatologists and I have prenatal ultrasonologists who send these fathers generally with the ultrasound to me. And of course, you have some parents who come with a choroid plexus cyst and say, I want to be sure, I want to terminate this pregnancy because this is a cyst in the brain, I've been told. And of course, you know that none of them really require termination. On the other hand, you have generally from perhaps the lower socioeconomic group, people that turn up with what looks almost like an anencephaly, saying, no, I want to go ahead because we've had 3 abortions spontaneously, and this is our only attempt to have a child. So quite oftentimes it is dictated by the socioeconomic situation rather than science. But I worry about who's qualified to give this opinion, in my country, because most of the pediatric neurosurgeons end up facing these prenatal ultrasounds with questions, as I said. So you get somebody turning up with a small choroid plexus cyst and saying, you know, this is something wrong. I don't want any blemish in my child, so I want to terminate pregnancy. And you have to tell them that you don't. And most of the time, they don't believe you. But the truth of the matter is, how do we, and if you look back, I don't think, at least for me, I don't think I've ever had a formal training in prenatal ultrasound or prenatal MRI during my training in pediatric neurosurgery. So I worry whether I'm actually, qualified to give this opinion, and we don't have a great deal. I mean, the neonatologists or the prenatal ultrasonologists would give you the report, but they will never tell you about the prognosis. And they say, go to a pediatric neurosurgeon. So I just want to know what advice you'd give to people who do not have the benefit of these experts that both of you share, that you have.
Yes. Sandip, you're paying a price for being so authoritative. That's a price that I'm paying as well. And prenatal counseling takes forever. And I just do not agree to sit in committees with more than 2 people, 10 people, everybody talks. It takes hours and hours. There's one thing that you have to do is whatever you tell the parents, document it, keep your horizons open, discuss our inability to provide prognosis for a single fetus. We never know what a single fetus will be like. And we never know how the society and the parents will accept the morbidity of a single fetus. So keep your advice very wide and document everything you're saying.
There is a question on that. There is a question from a questioner which says, is there a formal training course for interpreting prenatal ultrasound? And should pediatric neurosurgeons have to have that in their curriculum during training now?
There is no training course for, at least for neurosurgeons. There is some training course for radiologists. The only thing I want to say is that if you want to be involved in antenatal counseling, and if you are going to do a lot of cases, you need to go and see the ultrasound. Because on the opposite of the MR, where you can get all the sequences and discuss on all the sequences, it's impossible, even if you have some movies, to be sure to what happened during the ultrasonography. That means that I spend time to go to the radiological department and see all the difficult ultrasound when we have a decision to take. And I know now to do the ultrasound by myself, but I take hours to do that. And I spend now 20% of my time to do prenatal counseling and prenatal examination.
Well, just to say that I just was last week at the office of Mullinger, who's opening a fellowship for prenatal imaging. But this is new, it's really pioneering. And I think more and more places will open a fellowship. I don't think it is justified for a neurosurgeon to spend so much hours on becoming a hands-on maestro. But people who want to come into the ultrasound from the imaging side, from the gynecological side, have to have a proper training, first of neuroanatomy of the fetus, and then of ultrasound of the fetus. Not only neuro, by the way, the whole body.
Here's a very aggressive question. It says, given that operating on open neural tube defects has been shown to have good results, is it unethical to deny in utero surgery for open neural tube defects to a mother?
The discussion is not like that. The discussion goes through several points. Again, there is no, at the moment where we are speaking, no treatment for myelomeningocele. What the discussion starts with the parents to explain what is a myelomeningocele and tell them that you have the possibility of terminate the pregnancy And in my country, it rises up to 90%, 95% of termination of pregnancy, or to go to the end of the pregnancy and to operate after birth. If the parents decide to do termination of pregnancy, there is no problem, and this is accepted in all the cases. If they decide to continue the pregnancy for any reason, and one of the problems to answer to Shlomi, 10 years ago, I've seen 1 melanomeningocele for 12 million inhabitants in 1 year. Now we rise up to 50, and only for religious reasons. Because in France, we have more and more religious people who want, whatever is the malformation, to continue the pregnancy. And this is the only one that we set up an antenatal program. So if ever they want to continue the pregnancy, and only at this moment, we tell them, you know, there is two possibilities: to do the surgery after birth or before birth. There is now some good evidence that it will decrease the ratio of hydrocephalus, it will improve the walk, it will never cure the sphincter problem, never. And on the other hand, there is a risk of prematurity, and there is a risk for the mother, because all fetal surgery is a mother-fetal surgery. And after that, we have a huge discussion. And at this moment, we decide together to do the antenatal surgery. And so we do not deny to anybody to do fetal surgery, but this is a long process to do it. And we never do it. We always ask for 1 week of reflection, of thinking, before doing this surgery.
Okay, last question for you, Michel, because we're running out of time. Okay. What about hydrocephalus? Do you think there is currently evidence to suggest prenatal surgery for hydrocephalus?
For hydrocephalus, except for melanomeningocele, hydrocephalus isolated, you would say. Sandip?
Yeah.
There is absolutely no clue in the literature for the moment to do treatment for hydrocephalus. No one.
Shlomi, you'd agree with that? You obviously have, because...
Absolutely, and I would add, I agree to Michel about his view on providing or denying prenatal surgery for open defects. There's no sense to suggest it for people who want to terminate the pregnancy. I have big problems with the data of the moms, and I have big problems with drifting from open surgery, which is the most, to fetal endoscopic surgery with no randomized prospective study. But even though I think that people who come in time, and this may not be relevant, for example, for the ultra-religious who come to me already at 30 weeks, etc., and more advanced, if they come in time, I have to provide them the information that such an option exists.
Okay, we've just got so many questions. I'm going to have to ask you one more last question, because this is a question from Ethiopia, where a neurosurgeon says that, you know, we don't have routine prenatal ultrasound screening, but we do have MRI available. Should we send our patients to have MRIs during pregnancy, and when should we do so, if at all? And what's the difference between prenatal MRI and MRI that we do in adults? So do you want to answer that, Shlomi, quickly?
Yes. Prenatal MRIs are a sub-specialization. Very difficult to interpret. It's not for a routine neuroradiologist to interpret. So I would not advise to use a routine MRI performer as a substitute for an ultrasound.
And final question from Kenichi in Japan. He says, as far as I know, prenatal ultrasound defines anatomy. Do you guys think that it defines physiology as well? Or do you guys know any other way of actually understanding the physiology? Because that's what we're interested in more than the anatomy. And I'll let both of you have a quick answer. Michel, is there a way of understanding the physiology, or are we just looking at anatomy and giving a prognosis?
No, I don't think that, except for CSF movement and blood circulation, we can't say more for the moment.
Yes.
Shlomi, you want to add something?
Very little. There is movement of the legs, movement of the hands, doing a Doppler on circulation, and having some CSF motion, but it's very limited.
Great. As we come to the end of this debate, and I think we've talked a lot about prenatal surgery, I think we should let somebody who comes from a country where there is a lot of prenatal surgery have the last word. So I'll bring in the president of the ISPN to give his comments on prenatal surgery before we call it a day. Francisco.
Thank you. Thank you. There are actually in Brazil 5 or 6 centers devoted to prenatal surgery. At our hospital, we don't perform prenatal surgery because we think we don't have all the requirements we should have. We are a small maternal infantile hospital. We don't have great risk pregnancies. Our focus is risk of newborn risk. But there is a lot of people doing this. I think, as Shlomo said, there is no randomized study, and this benefit for me is still to be defined. But I have the impression that, despite my personal opinion, that's a situation that is here to stay. And I will tell you why. Because more and more people are aware that they can solve the problem of the fetus going to prenatal surgery. And we had already some cases that had medical legal issues regarding this. But that's still something that's incipient in Brazil. Thank you.
Thank you. Thank you very much, Francisco. And that brings us to the end of the first Clash of the Titans from the Education Committee of the ISPN. It just it remains for me to thank profoundly our 2 titans who clashed today. Professor Shlomi Constantini from Tel Aviv, Professor Michel Zerah from Paris. Thank you very much. And for the audience who are bearing with us, this is an event that will occur every first and third Friday of the month. We've brought to you by the Education Committee of the ISPN at 1 p.m. GMT. And as we say goodbye, we will share with you the screen that will tell you the next debate, which is on fortification of cereals with folic acid is absolutely needed for prevention of open neural tube defects. And you can see the 2 speakers on your screen. And with that, I would take your leave. Thank you very much. Have a great day or night. Thank you. Bye-bye.
Bye-bye.
Thank you.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.
Thank you.